Thanks very much for giving me the opportunity to present some of our work. We're quite a large team of collaborators who are working on this question of how do you look at virus, and suppression in plasma and cerebrospinal fluid in adolescents, especially when you need sort of 1 million PBMCs or something to actually find the reservoir in children. So luckily we had the SURE cohort, or 2 of our representatives and some of our people up here earlier. So that is the study that I work on, and this is a follow-on of this when the children were 17 years of age. And we were funded through the Martin Delaney Pediatric Adolescent Virus Elimination group. And the key question is, does HIV persist in the CNS of adolescents who received early antiretroviral therapy? Because this is one of the earliest cohorts who's received early antiretroviral therapy. Impact 2015 showed that the virus does exist in the CSF in some participants. They were slightly older. And we did a cross-sectional study, children between 16 and 19 who started antiretroviral therapy early. It wasn't easy because this is sort of a cross-bridging age, especially for all the neurocognitive tests when they change to adult tests. And we didn't want to use them at the bottom kind of baseline of the adult testing. So our investigations were neurocognitive assessments, neuroimaging, and spiral taps. Spinal fluid taps. We also have blood that we've stored where we're going to look at reservoir. It's actually ongoing at the moment, genetics and antibodies and the immune biomarkers which will be assessed. There were 80 adolescents enrolled, 40 in Cape Town and 40 in Johannesburg at PHRU and FAMCRU. One participant was excluded due to pregnancy. There actually isn't really a contraindication to doing an LP in pregnancy or neuroimaging with an MRI, but we just felt, no, this is kind of a study and we need to just keep that patient safe. So actually we had 79 who had CSF viral load measures. This is a description of the participants. There was quite a tight age band. The median age of starting antiretroviral therapy was 8.2 weeks. Time on antiretroviral therapy, 16.3 years. Body mass index was, there was actually 0.3, with some going down to minus 0.9. Unfortunately, we had a few issues with the laboratory, so just for this, these preliminary results, we're only reporting on 65 participants with CD4 counter median of 715, CD8 783, and the CD4-CD8 ratio 0.9. As in all studies, most mentioned today, there were more females, and 66% had already transitioned to TLD. We also used a questionnaire, and I wanted to present a lot more of this, but I've only got 10 minutes. And the children so were asked questions that they responded to. I get tired easily. I find that I lack energy. I'm not happy with my weight, my change in weight. And you can see the first two, they're tired easily and they lack energy. This does need a little bit more exploration because we used the PHQ-9 for depression questionnaire, and the one thing that came out compared to other reports from other cohorts was that they were also tired. And first we said, okay, is it summer? You know, were they all hot when we questioned them? Is it this? We tried to look at a lot of permutations, but we couldn't actually find anything that described it. So of the participants, almost a third had detectable blood, HIV in their blood and their CSF, which actually we were quite shocked at because they are our darlings. You know, we followed them up since they were babies, and but yesterday, that's just about what everyone else was reporting in the adolescents, about 27%, 28%, 34%. So it actually fits in quite nicely. One of the things is that we could go down to target not detected at less than 20. So we can report that quite good suppression rates. But we also found that there were 2 who only had virus in their blood, and there were another 3 who only had virus in their CSF and not detectable in their blood. There was a very strong correlation between the CSF viral load with the blood viral load as well. And this needs to be explored further. All right. As far as the characteristics, we divided the groups into those less than 20 copies, which are the target not detected or suppressed, and then those up to 400 and those with greater than 400 copies. And there was no difference between the groups there. So you also think, well, you know, the ones who are unsuppressed, they're probably the children who are using more recreational drugs or things, but that wasn't the case here. All right. And as far as our neurocognitive scores go, we were looking at frontal lobe, adolescent development, trying to, attention's got to come through, working memory, also the processing speed, and then some executive function tests. Now, I've taken out a lot of the subtests just to make the slide not so busy. And the only one that really showed a difference between groups was the digit span, and that one was the digit span backwards. But if you look at some of the results, you will see that those 11 with higher, actually have higher scores than the 11 with detectable virus greater than 400 copies per mil actually have higher results than the others. And that really needs to be explored, but not for this presentation. Okay. We found quite a discrepancy in self-reporting on the drug use disorders identification test, where 20% of those who said, I've never had taken any drugs, actually were positive on the day. We actually tested them. They came for 3 visits, and we tested them at each visit. And 58% who said, oh, I only use once monthly, less than once a month, that they were also positive. And I thought, did we now start suggesting that, because we're asking these questions, that it's supposed to be like common factor and common behavior. Tembi, our social worker, does a good job on Saturdays talking to participants and kind of negotiating. But I looked at it, and the longest time between the do it and the drug test was actually 6 weeks. There was some done on the same day, and there was some on a few days. So I don't think that their behavior would have changed in time between the 2 assessments. So almost a third of our participants were unsuppressed, with almost all of them having HIV RNA in the CSF. The results between the plasma and the CSF were strongly correlated, but there were no differences that we could really pick up in the viremic groups between the participant characteristics and the neurocognitive outcomes. There's a high prevalence of cannabis use. Urine drug tests are much better than the DUDIT. We also did the audit, but we didn't have anything to corroborate it with, so I didn't even report it now. And these data are preliminary data, and additional research is, and we're really looking forward to seeing what those biomarkers look like in the CSF and blood. And then just to acknowledge everyone who's involved, the bravery of the participants, our IRB asked us, is it unethical because they feel loyal to us and they will say yes to LPs, but we had very good methods for pain, trying to decrease pain and support them. Thanks.
Thank you.